Hi, welcome back everyone. Let's start our discussion with figure 45, effect of heart failure treatment on the Frank-Starling curve. Figure 45, which illustrates one of the most important physiological concepts in heart failure. The graph compares a normal heart, a failing heart, and the improvement that occurs after appropriate heart failure treatment. On the horizontal axis, we have left ventricular end diastolic pressure, which represents preload, while the vertical axis represents stroke volume or cardiac output. In a healthy heart, increasing preload results in a substantial increase in stroke volume. However, in heart failure, the Frank-Starling curve becomes flattened. This means that despite increasing filling pressure, the ventricle is unable to generate a meaningful increase in cardiac output. Instead, excessive preload mainly leads to pulmonary congestion, causing symptoms such as dyspnea and orthopnea. The rationale behind heart failure treatment is therefore twofold. Reduce afterload so the failing ventricle ejects blood more easily, improve myocardial contractility when necessary to increase cardiac output. Figure 45 also demonstrates how different therapies influence the curve. A represents diuretic or venodilators such as nitrates, which reduce preload and relieve pulmonary congestion. A also represents more aggressive diuresis or venodilation, producing a greater reduction in filling pressure. I represents positive inotropic agents which improve myocardial contractility and increase stroke volume. D represents ACE inhibitors which reduce afterload through vasodilation, allowing the ventricles to eject blood more efficiently. And B represents the combination of an inotropic plus an ACE inhibitor, producing the greatest improvement in cardiac performance. The overall goal is to move the patients from the failing heart curve toward a more normal Starling curve while simultaneously reducing symptoms of congestion. Sleep disordered breathing. Sleep disorders are extremely common in patients with congestive heart failure. Approximately 40% of patients develop central sleep apnea, often associated with shiny strokes respiration, while about 11% have obstructive sleep apnea. These breathing abnormalities are not merely symptoms. They are also associated with the worsening left ventricular dysfunction, increased sympathetic nervous system activation, recurrent nocturnal hypoxia, and a high hospitalization rate, and also poorer overall prognosis. Treatment of sleep apnea may improve both quality of life and cardiac function. For patients with obstructive sleep apnea, nasal CPAP is frequently beneficial. Besides improving sleep quality, CPAP decreases sympathetic activation, reduces nocturnal hypoxia, and may provide secondary improvements in cardiac performance. Cardio-oncology. An increasingly important field is cardio-oncology, which focuses on preventing and managing cardiovascular complications of cancer therapy. Many chemotherapeutic agents can produce cardiotoxicity, making them an important cause of long-term morbidity and mortality among cancer survivors. One classic example is anthracycline class of chemotherapy, which causes dose-dependent left ventricular systolic dysfunction. Another important drug is trastuzumab, which may also reduce left ventricular ejection fraction. Fortunately, this decline is often reversible if detected early. Management begins with identifying cardiovascular risk factors before chemotherapy starts. Patients should undergo baseline cardiac evaluation and receive optimal treatment for pre-existing cardiovascular disease before, during, and after cancer therapy. Cardiac monitoring should remain consistent throughout treatment using the same imaging techniques such as echocardiography, contrast echocardiography, global longitudinal strain or GLS, three-dimensional echocardiography, or MUGI scan. These studies allow clinicians to detect even subtle declines in ventricular function. According to the Canadian Cardiovascular Society guidelines, any patient who develops symptomatic heart failure or experiences an asymptomatic fall in left ventricular ejection fraction, defined as a reduction greater than 10% from baseline, or an left ventricular ejection fraction below 53%, should receive appropriate heart failure management. Myocardial disease. Now we begin a new section entitled Myocardial disease, starting with the definition of cardiomyopathy. Cardiomyopathy refers to an intrinsic or primary disease of the myocardium that is not secondary to congenital heart disease, hypertension, coronary artery disease, valvular disease, or pericardial disease. These disorders produce both structural and functional abnormalities of myocardium. Cardiomyopathies are traditionally classified into three major groups. Number 1, dilated cardiomyopathy. Number 2, hypertrophic cardiomyopathy. And number 3, restrictive cardiomyopathy. A common misconception involves ischemic heart disease. Although patients with previous myocardial infarction may develop severe left ventricular dysfunction, this is not considered a true primary cardiomyopathy because the underlying pathology is coronary artery disease rather than a primary myocardial disease. Table 16, comparison of cardiomyopathies, secondary causes and consequent heart failure phenotypes. Let's now examine Table 16. This table categorizes cardiomyopathies according to the type of heart failure they usually produce. Heart failure with reduced ejection fraction, or HF-REF. The principal primary cardiomyopathy is dilated cardiomyopathy, or DCM. Common causes include idiopathic disease, viral myocarditis, alcohol toxicity, familial or genetic disorders, and collagen vascular disease. Secondary causes producing heart failure with reduced ejection fraction include coronary artery disease, previous myocardial infarction, diabetes mellitus, and significant valvular disease such as aortic regurgitation and mitral regurgitation. Heart failure with preserved ejection fraction, or HFpEF. Two primary cardiomyopathies are emphasized. First is hypertrophic cardiomyopathy, or HCM, which usually results from mutations affecting sarcomere proteins and is the most common cause of sudden cardiac death in young athletes. Second is restrictive cardiomyopathy, or RCM, characterized by impaired ventricular filling despite relatively preserved systolic function. Important causes include amyloidosis, sarcoidosis, scleroderma, hemochromatosis, Fabry disease, Pompe disease, and Loeffler syndrome. Secondary causes of heart failure with preserved ejection fraction includes hypertension, diabetes mellitus, valvular disease such as aortic stenosis, post-myocardial infarction remodeling, and transient myocardial ischemia. This table provides an excellent framework for distinguishing primary myocardial diseases from secondary causes of heart failure and understanding whether patients typically present with reduced or preserved ejection fraction. Sorry for that. To summarize this page, Figure 45 demonstrates how heart failure therapies improve cardiac output by reducing preload, reducing afterload, or increasing contractility. Sleep disordered breathing is common in heart failure and contributes to worse outcomes. CPAP may improve both symptoms and cardiac function. Cardio-oncology emphasizes early detection and monitoring of chemotherapy-induced cardiotoxicity using serial imaging. Cardiomyopathies are primary myocardial disorders classified as dilated, hypertrophic, or restrictive. Table 16, comparison of cardiomyopathies, secondary causes, and consequent heart failure phenotypes, organizes cardiomyopathies according to whether they cause heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, and highlights their major etiologies. Now let's start with myocarditis. Myocarditis is an inflammatory process involving the myocardium or heart muscle. The disease may present as an acute illness or evolve into a chronic inflammatory condition. Clinically, myocarditis is particularly important because it is one of the major causes of dilated cardiomyopathy or DCM, especially in younger patients. The severity varies tremendously. Some individuals experience only mild fatigue or flu-like symptoms, while others develop fulminant myocarditis leading to severe heart failure, cardiogenic shock, or even sudden cardiac death. Etiology. The first category is idiopathic myocarditis, where no specific cause can be identified. The second and most common category is infectious myocarditis. Among infectious causes, viral infections are the leading cause worldwide. Common viruses include Coxsackie virus A and B, parvovirus B19, adenovirus, influenza virus, ecovirus, poliovirus, HIV, mumps virus, and SARS-CoV-2, the virus responsible for COVID-19. Bacterial causes include Staphylococcus aureus, Streptococcus species, Clostridium perfringens, Corynebacterium diphtheria, Mycoplasma, and Rickettsia. Other infection organisms include fungi and parasites. Examples include Lyme disease caused by Borrelia burgdorferi, Chagas disease caused by Trypanosoma cruzi, and Toxoplasma gondii. Myocarditis may also result from toxic injury. Important toxins include excessive catecholamines, chemotherapy drugs, and cocaine. Another mechanism is hypersensitivity or eosinophilic myocarditis, which can occur after medications such as antibiotics, diuretics, lithium, or clozapine. Insect or snake bites may also trigger this response. Rarely, myocarditis has been reported following mRNA vaccination. Systemic inflammatory diseases are another important causes. Examples include systemic lupus erythematosus, rheumatoid arthritis, sarcoidosis, other autoimmune disease. Finally, rare causes include giant cell myocarditis and acute rheumatic fever. Signs and symptoms. The clinical presentation depends on the severity of myocardial inflammation. Many patients begin with the constitutional symptoms including fever, fatigue, malaise, and generalized muscle aches, often following a viral illness. As cardiac involvement develops, patients may present with acute congestive heart failure characterized by shortness of breath, tachycardia, elevated jugular venous pressure, and severe diseases can progress to cardiogenic shock. Chest pain is common and may resemble either pericarditis or acute myocardial infarction because inflammation can involve both the myocardium and surrounding pericardium. Electrical instability of the heart can produce arrhythmias ranging from benign premature beats to life-threatening ventricular tachyarrhythmias. Patients may also develop systemic or pulmonary emboli because impaired ventricular contraction promotes thrombose formation. Unfortunately, myocarditis can also present with presyncope, syncope, or sudden cardiac death, particularly in young adults. Investigations. Evaluation begins with the electrocardiogram or ECG. The ECG often shows non-specific ST wave abnormalities or conduction defects. Although these findings are not diagnostic, ECG serves as an important initial screening and risk stratification tool. Echocardiography. Echocardiography helps evaluate cardiac structure and function. In fulminant myocarditis, the heart may initially have a spherical shaped ventricle while gradually remodels into the normal elliptical shape during recovery. Blood work. Several laboratory tests support the diagnosis. Markers of myocardial injury include creatine kinase, cardiac troponin I, cardiac troponin T. If heart failure develops, NT-proBNP becomes elevated. Inflammatory markers such as C-reactive protein, erythrocyte sedimentation rate, increased white blood cell count may also be elevated. Autoimmune investigations include anti-nuclear antibodies, rheumatoid factor, complement levels. When infection is suspected, blood cultures, viral serology, and testing for mycoplasma may be performed. Chest X-ray. Chest radiography may reveal an enlarged cardiac silhouette, especially when ventricular dysfunction is significant. Transthoracic echocardiography or TTE. TTE commonly demonstrates dilated ventricles, reduced systolic function, hypokinetic chambers, segmental wall motion abnormalities. Some patients may also have evidence of systolic dysfunction. Cardiac magnetic resonance imaging, or CMR. In other words, cardiac MRI. Cardiac MRI has become one of the most valuable diagnostic tools. It identifies both functional abnormalities and tissue pathology, particularly through gadolinium enhancement, which demonstrates myocardial edema, inflammation, and fibrosis. Endomyocardial biopsy. Although considered the definitive diagnostic test, endomyocardial biopsy is performed only in selected clinical situations, particularly patients requiring inotropic support or mechanical circulatory support. Coronary angiography. Finally, coronary angiography may be required to exclude obstructive coronary artery disease, especially when myocarditis presents with chest pain and elevated cardiac biomarkers. Management. Treatment is primarily supportive. Patients with cardiogenic shock require aggressive management, including mechanical circulatory support and inotropic therapy when necessary. During recovery, patients should avoid strenuous physical activities because exercise may worsen myocardial inflammation and increase the risk of arrhythmias. If persistent heart failure develops, treatment follows standard heart failure guidelines, including guideline-directed medical therapy. Patients with advanced heart failure may require ventricular assist devices or heart transplantation. Arrhythmias should be treated according to standard protocols. Anticoagulation is considered when there is a ventricular thrombus or a high risk of embolization. Whenever possible, the underlying cause should also be treated. For example, discontinuing an offending medication or treating an infectious or autoimmune disorder. Prognosis. The prognosis of myocarditis is highly variable. Many cases remain unrecognized and resolved spontaneously without long-term consequences. However, patients with clinical significant myocarditis have a 5-year mortality of approximately 25 to 50%, emphasizing the importance of early recognition and appropriate management. Giant cell myocarditis, although uncommon, carries an extremely poor prognosis. It often presents with fulminant heart failure and has a 5-year mortality exceeding 80%. Myocarditis is also an important cause of sudden cardiac death in young adults, particularly athletes. Finally, chronic inflammation may lead to dilated cardiomyopathy, resulting in progressive ventricular dysfunction and chronic heart failure. To conclude this page, myocarditis is an inflammatory disease of the myocardium with presentations ranging from mild viral symptoms to cardiogenic shock. Viral infections remain the most common cause, although toxins, autoimmune diseases, and hypersensitivity reactions are also important. ECG cardiac biomarkers, echocardiography, and cardiac MRI are the cornerstone investigations, while endomyocardial biopsy is reserved for selected patients. Management focuses on supportive care, treatment of heart failure and arrhythmias, activity restriction, and addressing the underlying cause. Although many patients recover completely, myocarditis can progress to dilated cardiomyopathy, severe heart failure, or sudden cardiac death if not recognized promptly. Let's begin with the definition of the dilated cardiomyopathy. Dilated cardiomyopathy is characterized by unexplained dilation of one or both ventricles accompanied by impaired systolic function. In other words, the heart chambers become enlarged and weakened, reducing their ability to pump blood effectively. An important point is that if a patient has coronary artery disease or CAD, the degree of coronary disease should not fully explain the severity of ventricular dysfunction. If ischemia alone explains the poor ventricular function, then the diagnosis is ischemic cardiomyopathy rather than dilated cardiomyopathy. Etiology. The most common causes accounting for approximately 60% of cases is familial or genetic disease. Therefore, obtaining a detailed family history is extremely important. The second most common cause is chronic alcohol consumption, responsible for approximately 20 to 30% of cases. Alcohol has a direct toxic effect on the myocardium, and prolonged heavy drinking can eventually produce irreversible ventricular dysfunction. Another major cause is myocarditis, especially following viral infections. Infectious causes include Coxsackie virus B, HIV, SARS-CoV-2 virus, Chagas disease, Lyme disease, rickettsial infectious, acute rheumatic fever, toxoplasmosis. These infections may directly damage myocardial cells or trigger immune-mediated inflammation. Next are connective tissue and collagen vascular diseases, including systemic lupus erythematosus, polyarteritis nodosa, dermatomyositis, progressive systemic sclerosis. Many patients remain idiopathic, meaning no definite cause is identified, although many are presumed to have had a previous viral myocarditis. Persistent, uncontrolled tachyarrhythmias, particularly rapid atrial fibrillation, may produce tachycardia-induced cardiomyopathy, which is potentially reversible if the rhythm is controlled. Neuromuscular disorders can also lead to DCM, including Duchenne muscular dystrophy, myotonic dystrophy, Friedreich's ataxia. Metabolic and nutritional deficiencies are important reversible causes. They include uremia, thiamine deficiency, selenium deficiency, carnitine deficiency, endocrine disorders also include. Endocrine disorders may be hyperthyroidism, hypothyroidism, diabetes mellitus, phenochromoscytoma. Pregnancy-related peripartum cardiomyopathy is another recognized cause. Several toxins contribute to DCM, including cocaine, heroin, organic solvents. Drug-induced cardiomyopathy may occur with doxorubicin, cyclophosphamide, antiretroviral drugs, chloroquine, clozapine, tricyclic antidepressants. Finally, radiation therapy involving the chest may also damage the myocardium and result in dilated cardiomyopathy. Example: major risk factors of DCM. The margin of the page highlights the major risk factors: positive family history, alcohol abuse, and cocaine use. These are frequently tested on examinations. Signs and symptoms. Patients usually present because of complications arising from impaired systolic function. The most common presentation is heart failure with reduced ejection fraction producing dyspnea, fatigue, orthopnea, peripheral edema. Because blood flow becomes sluggish within the dilated chambers, patients are at increased risk of systemic or pulmonary emboli. Electrical instability of the enlarged heart predisposes patients to atrial and ventricular arrhythmias. Unfortunately, one of the leading causes of mortality is sudden cardiac death, usually resulting from fatal ventricular arrhythmias. Investigations. Now let's review the investigations. Blood work. Routine laboratory testings includes complete blood count, electrolytes, creatinine, biocarbonates, BNP, creatine kinase, troponin, and liver function test, TSH, and total iron binding capacity. These tests help identify heart failure severity as well as reversible causes. ECG. Electrocardiographic findings are variable and may include non-specific ST wave abnormalities, poor R wave progression, conduction defects such as bundle branch block, various atrial or ventricular arrhythmias. Chest X-ray. Chest radiography typically demonstrates global cardiomegaly, sometimes called the globular heart, pulmonary congestion, pleural effusion, other signs of congestive heart failure. Echocardiography. This is the most important diagnostic investigation. Typical findings include dilated cardiac chambers, global hypokinesis, reproduced left ventricular ejection fraction, functional mitral regurgitation, functional tricuspid regurgitation, and occasionally intracardiac thrombi. Cardiac MRI. Cardiac MRI is useful for identifying myocardial fibrosis, assessing tissue characteristics, and helping determine the underlying cause. Endocardial biopsy. Routine biopsy is not recommended. It is reserved for selected patients in whom identifying a treatable cause would alter management. Coronary angiography. Coronary angiography is performed in selected patients to exclude ischemic heart disease as the cause of ventricular dysfunction. Exam Pearl. Exam Pearl is abnormal laboratory findings in DCM. The margin summarizes several laboratory abnormalities commonly seen: elevated BNP, elevated creatinine, elevated liver function tests, low bicarbonates, low serum sodiums. These abnormalities generally reflects the advanced heart failure and poorer prognosis. Management. Management begins with treating the underlying cause whenever possible. For example, complete abstinence from alcohol, treatment of thyroid disease, correction of nutritional deficiencies, and management of myocarditis or infection when appropriate. Heart failure should then be treated according to the standard heart failure guidelines, including guideline-directed medical therapy. Patients who remain symptomatic despite optimal medical therapy may require device therapy such as implantable cardioverter defibrillator or ICD for prevention of sudden cardiac death, and cardiac resynchronization therapy CRT in appropriately selected patients with ventricular dysynchrony. Patients with advanced refractory disease may ultimately require left ventricular assist device or LVAD, heart transplantation, selected surgical procedures such as ventricular volume reduction surgery. Because intracardiac thrombi are common, patients with atrial fibrillation, previous thromboembolism, and documented ventricular thrombosis should receive anticoagulation with warfarin. Arrhythmias should be managed appropriately to reduce symptoms and prevent sudden death. Preventive care includes influenza and pneumococcal vaccination. And finally, if no clear cause is identified, first-degree relatives should be screened since many cases have genetic basis. Prognosis. Outcome depends largely on the underlying etiology and generally parallels the prognosis or systolic heart failure. Patients with reversible causes such as alcohol-induced disease, inflammatory cardiomyopathy, HIV-associated cardiomyopathy, or drug-induced disease often experience significant improvement once the underlying cause is corrected. Early initiation of optimal heart failure therapy, including medications and appropriate device therapy, promotes reverse remodeling and improves long-term survival. The presence of myocardial fibrosis on cardiac MRI predicts higher risk of sudden cardiac death. Death most commonly occurs due to progressive pump failure causing congestive heart failure, fatal ventricular arrhythmias. Systemic emboli remains an important cause of morbidity. Overall mortality remains significant, with approximately 20% mortality during the first year after diagnosis, followed by about 10% mortality per year thereafter. To conclude this page, dilated cardiomyopathy is characterized by ventricular dilation with impaired systolic function. The most common causes are genetic disease, chronic alcohol use, and myocarditis. Patients usually present with heart failure, arrhythmias, thromboembolism, or sudden cardiac death. Echocardiography is the cornerstone of diagnosis, while cardiac MRI helps detect myocardial fibrosis. Management focuses on treating the underlying cause, guideline-directed heart failure therapy, ICD, CRT when indicated. Anticoagulation is selected in selected patients, and advanced therapies such as LVAD or transplantation for refractory disease. Prognosis depends on the cause, but early recognition and optimal treatment can significantly improve outcomes. Hypertrophic cardiomyopathy. Let's begin with the definition of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is defined as an unexplained left ventricular hypertrophy, or LVH. The hypertrophy cannot be explained by other conditions such as long-standing hypertension or aortic stenosis. The pattern of hypertrophy may involve different regions of the left ventricular, but asymmetric septal hypertrophy is by far the most common pattern. Two classic echocardiographic findings are systolic anterior motion, or SAM, of the mitral valve and hyperdynamic left ventricle. Although these findings are common, they are not diagnostic on their own. Etiology. Moving on to the causes of HCM. HCM is primarily a genetic disease involving mutations in a protein that make up the cardiac sarcomere. More than 400 mutations have been identified. The inheritance pattern is autosomal dominant, but there is a incomplete penetrance, meaning not every individual carrying the mutation develops clinical disease. The age at presentation is also highly variable. Approximately 70% of pathogenic mutations occur in two genes. MYH7, which encodes beta-myosin heavy chain, MYBPC3, which encodes myosin-binding protein C. The prevalence is estimated to be 1 in 500 to 1 in 1,000 people in the general population. Although men and women are affected equally genetically, women are diagnosed less frequently. Most patients present during early adulthood, although diseases can occur at any age. Pathophysiology. Now let's understand what happens inside the heart. Microscopically, HCM is characterized by myocyte disarray, which is the hallmark pathological feature, myocyte hypertrophy, dysplastic intramural arterioles, and interstitial fibrosis. Many patients develop dynamic obstruction of the left ventricular outflow tract, or LVOTO. This occurs because of the two mechanisms. Number one, septal hypertrophy. Number two, systolic anterior motion of the mitral valve, or SAM. The thickened ventricle also becomes stiff, leading to diastolic dysfunction. This is caused by hypertrophy, myocardial ischemia, and fibrosis. Patients frequently develop myocardial ischemia not because of blocked coronary arteries, but because of oxygen demand exceeds supply. Finally, abnormalities of the autoimmune nervous system contributes to inappropriate vasodilation during exercise and poor heart rate recovery after exercise. Hemodynamic classification. HCM is divided into two major categories. The first is hypertrophic obstructive cardiomyopathy, or HOCM. This is defined by a peak left ventricular outflow tract gradient of at least 30 millimeters of mercury, either at rest or after provocation. However, when the gradient reaches 50 millimeters of mercury or greater, either at rest or with provocation, this is generally the threshold for considering septal reduction therapy if symptoms persist despite optimal medical treatment. The second type is non-obstructive HCM, which accounts for approximately 1/3 of patients. In these patients, there is no significant left ventricle outflow tract obstruction. Signs and symptoms. Clinical presentation varies widely. Many patients remain asymptomatic, making family screening is extremely important. When symptoms occur, they commonly include shortness of breath on exertion, angina, syncope, heart failure symptoms, cardiac arrhythmias, sudden cardiac death. On carotid pulse examination, patients with obstructive disease often demonstrate the classic spike and dome pulse, reflecting dynamic obstruction. During precordial palpation, you may detect a localized, sustained apex beat, a double impulse. In obstructive disease, even a triple ripple, also called the triple apical impulse, may be heard. And the left ventricular left. On osculation, the second heart sound may be normal or paradoxically split. A fourth heart sound, or S4, is common due to the stiff ventricle. The characteristics murmur is a harsh systolic diamond-shaped ejection murmur, best heard along the left sternal border or at the apex. One important examination pearl is that this murmur becomes louder when standing or the Valsalva maneuver, because this reduces preload and worsens left ventricular outflow tract obstruction. This behavior helps distinguish HCM from aortic stenosis, whose murmur usually becomes softer during these maneuvers. Many patients also have a pansystolic murmur due to associated mitral regurgitation. Investigations. Let's finish by discussing the investigations. A 3-generation family history should be obtained because of the hereditary nature of the HCM. First-degree relatives should undergo cascade genetic testing when appropriate, screening with transthoracic echocardiography and electrocardiography. If initial normal and asymptomatic screening should continue. Every 1 to 3 years in children, every 3 to 5 years in adults. Transthoracic echocardiography. This is the first line investigation. It confirms the diagnosis, monitors disease progression every 1 to 2 years, and evaluates obstruction. If testing left ventricular outflow tract obstruction is absent, exercise or provocative test is performed to detect latent obstruction. Transesophageal echocardiography, TEE. TEE is mainly used before septal reduction procedure. It helps evaluate mitral regurgitation, systolic anterior motion, severity of left ventricular outflow tract obstruction. Cardiac MRI. Cardiac MRI is useful when echocardiographic findings are inconclusive. It also assists in planning septal reduction therapy and identifies myocardial fibrosis through the late gadolinium enhancement and important marker of arrhythmic risk. Electrocardiogram and Holter monitoring. ECG often demonstrates left ventricular hypertrophy, high precordial voltage, prominent Q waves in leads 1, AVL, V5, and V6. Tall R wave in V1, P wave abnormalities. Holter monitoring is performed during initial assessment and follow-up to detect arrhythmias and estimate the risk of sudden cardiac death. Cardiac catheterization. Cardiac catheterization is generally reserved for patients being considered for invasive therapy. Genetic testing. Finally, genetic testing helps confirm uncertain diagnosis and facilitates screening of family members. Figure 46. ICD implantation in HCM. Now let's conclude with figure 46. ICD implantation in HCM, which summarizes decisions regarding implantation of an implantable cardioverter defibrillator or ICD. The algorithm begins by asking whether the patient has experienced previous cardiac arrest, sustained ventricular tachycardia, or sudden cardiac death, even that was successful resuscitated. If yes, an ICD is strongly recommended as secondary prevention. If not, the next step is assessing major risk factors including family history of sudden cardiac death, massive left ventricular hypertrophy, unexplained syncope, apical aneurysm, and left ventricular ejection fraction below 50%. When one or more of these risk factors are present, ICD implantation is considered reasonable. If these are absent, clinicians evaluate for non-sustained ventricular tachycardia, especially in children, extensive late gadolinium enhancement on cardiac MRI, particularly in adults. These findings may justify ICD implantation in selected patients. If none of these risk factors are present, an ICD is not indicated, and the patient should continue routine surveillance and medical management. To conclude this page, HCM is the most common inherited cardiomyopathy caused by mutations in sarcomeric proteins. Asymmetric septal hypertrophy is the classic morphological pattern. Dynamic left ventricular outflow tract obstruction results from septal hypertrophy and systolic anterior motion of the mitral valve. Patients may present with dyspnea, angina, syncope, arrhythmias, or sudden cardiac death, although many remain asymptomatic. Echocardiography is the cornerstone of diagnosis, while cardiac MRI improves risk stratifications. Figure 46 provides practical algorithm for identifying patients who should receive an ICD to prevent sudden cardiac death. Thank you for attending the lecture. If you're new to the channel, don't forget to like and subscribe and press the bell icon. So, see you in the next lectures.